So today I'll be talking about management of miscarriages and the management of maternal sepsis. And I'll also have a few words on the ectopic pregnancy. When we look at the management of miscarriage, it's important to recognize a miscarriage, it being safe, unsafe, or septic. We need to learn how to perform a manual vacuum aspiration. You need to learn how to recognize and manage maternal sepsis, and you need to achieve competence in all the above skills. And one may ask a question, and what percentage of women plan to become pregnant, do become pregnant, are clinically pregnant, and spontaneously miscarry? And we're looking at a figure of around 15%. And when we take the annual birth rate in South Africa, where about 1.2 million births, 1.2 million babies are born, almost 200,000 mothers will have spontaneous miscarriages. And it's important to be able to classify these miscarriages so that we can be able to appropriately manage them. And we are all taught from medical school the type of miscarriages. We can have spontaneous miscarriages and those miscarriages that are induced. And under your spontaneous miscarriages, we have those that have threatened, inevitable, incomplete, missed, and complete. And for those that are induced, can be either medically indicated termination or the termination of pregnancy as per patient request. And most of the patients that will come with complicated miscarriages are those ones who actually go for backstreet miscarriages, whereby they seek interventions from people who are not actually registered to offer those services. So it's always important that when we have patients coming to us for such services, we need to really consider helping them rather than chase them away, because if the woman can't get help where she's supposed to get help, they'll definitely make sure that they get it somewhere. And under uncomplicated miscarriage, it's important to know that these patients can actually be managed at level 1 hospital or even at CHC, provided that the patient is stable. And that will be actually need to be assessed, and you need to make sure that all your patients' vitals are normal, like your pulse need to be less than 90, your respiratory rate need to be less than 20, your temperature should be normal, and the patient must at least have an HB of 10, and only those who have uteruses that are 12 weeks and less. You must also make sure that the products of conception are not foul-smelling, and there are no other clinical signs of infection, and there are no other suspicious findings on examination. Where in doubt, you need to refer these patients. And anything else, the patient will be managed at either level 1 and level 2 or 3. So those ones which can be managed at level 1 hospitals are those patients that have miscarriage, and that level 1 hospital should have a theater facility. Remember, I said the ones that you're gonna manage in the non-theater circumstances are those ones which are stable and 12 weeks and less. So anything else above that or beyond that should be managed in theater. And for level 1, the patient must have no organ system dysfunction. And if the patient have organ system dysfunction, they must be referred to level 2 or level 3. Importantly, we need to also recognize a complicated miscarriage. The most common complication is infection, whereby you can get fever, warm extremities. The patient will be tachypneic. They will have a tachycardia. They will also have altered mental state. They'll be hypotensive, and they may have signs of septic shock. The abdomen will be peritonitic, and the cervix might be open with foul-smelling discharge. And as I said, those ones who actually go for backstreet miscarriages, sometimes those backstreet miscarriages utilizes instruments that are quite traumatic, and the patient can also have evidence of trauma, like your cervical trauma. They can even sometimes actually have even bowel protruding through the cervix. So the management of your complicated miscarriage around this, the complication of sepsis actually overlap with the management of maternal sepsis. So I'll just go through the management of maternal sepsis, and then you'll all know that those patients also should be managed as such. So the aims of this presentation on maternal sepsis is that one need to learn how to recognize sepsis early and grade its severity. We need to learn how to manage the maternal sepsis, and we need to achieve competence in the management of these patients. And it's always important to recognize sepsis because most cases of severe morbidity and mortality occur because at initial assessment, the severity of illness is not appreciated. And you'll see what I mean by that as I go on. And it's important never to underestimate the risk associated with maternal sepsis. The question is, what percentage of women still die from sepsis? And sepsis accounts for at least 11% of direct obstetric mortality globally, and more than 200 women died from sepsis between 2014 and 2016 in South Africa. And we actually wrote an article in the ONG forum of 2018, Too Little Too Late. It was myself, Prof. Patterson, and one of our visiting Belgium doctors, and we published that article. And you can see how basic knowledge could have saved those women's lives. And there have been confusion and issues around the definition of maternal sepsis. And the diagnosis of maternal sepsis actually has been problematic because of lack of gold standard and accepted diagnostic criteria. You'll find that people have meetings, they are talking or presentations, and they are talking about maternal sepsis, and they refer to different things. One will say puerperal sepsis, one will say sepsis, one will say wound infection, and all that. And actually, before definition moved away from sepsis, severe sepsis, and septic shock because of the consequences actually which are associated with delays in management. People still trying to figure out, is this patient really septic, or is just sepsis, or is just you know, there were always confusions around those definitions. So in 2017, the World Health Organization released a statement on maternal sepsis definition, and this was basically to try to standardize the definition and make sure that when we talk about maternal sepsis, we talk about one thing and we understand each other in the same line. So maternal sepsis is defined as a life-threatening organ dysfunction caused by a dysregulated host response to infection during pregnancy, childbirth, post-abortion, or the postpartum period. And this was actually, this change was actually in line with the new sepsis 3 definition for general population. And before sepsis 3 definition, the definition were also looking at SARS, severe sepsis, septic shock, and all that. And this was actually decided that no, let's move from all those and then stick to this new definition of maternal sepsis. And as I said, this sepsis 3 was actually for the general population, and we extrapolated our maternal sepsis definition from there. And how are we going to recognize maternal sepsis? Fever, these are the clinical signs that we all know. Fever, home extremities, tachypnea, tachycardia, altered mental state, and we usually use a short AFPU because if you have to take a full GCS and assess it in a patient who's unstable, you know how time consuming that can be. So with your AFPU, you just look at your patient. Is your patient alert? If the patient is alert, at least you know that your patient's GCS is around 15/15. The minute it starts going to VPU, which is response to your voice, your pain, or unresponsiveness, you know that your patient has got an altered mental state. Also, your low blood pressure, looking at your systolic blood pressure of less than 100, and the presence of your septic shock. So it's either the mother has got, the woman has got maternal sepsis, or they are in septic shock, nothing in between. So your septic shock, as indicated by your shock index, I'll also talk about it later. And as I said, it's either your patient is in septic shock or it's got maternal pure sepsis. Nothing like severe sepsis. We don't use those definitions anymore. So when you look at the patient who's got septic shock, your shock index, this is basically your pulse rate divided by your systolic blood pressure. And your shock index should never be more than equal to or more than 1. So if you have a patient and you assess the patient and their shock index is greater than 1, and this is despite the normal blood pressure, should be regarded as critical. So let's take for an example, you've got a patient with a blood pressure of 120 over 80. In normal circumstances, this patient is not, this blood pressure is normal. However, when you look at this patient pulse, it's 143. And we all know that pregnant women compensate very well. So let's not be fooled by this blood pressure of 120 over 80, because if you calculate this patient's shock index is 1.2, and this signifies that your patient is in shock and they need immediate intervention. And you'll see as you continuously manage this patient, resuscitate them, your shock index will steadily decrease. And if it doesn't improve, it will tell you that either your resuscitation measures are not inadequate or your patient is getting worse. So furthermore, there are different scores that have been used around to assess the severity of organ failure in patients. And SOFA score, which is sequential organ failure assessment or septic associated organ failure assessment, is one of the scores that are used in critical care. And most of the time we use these scores in patients that are already admitted and we want to monitor their prognosis, and then we manage them accordingly. But if you can imagine having to do your SOFA score actually look at your patient from head to toe, all systems, your hematological, you'll see as I assess as I talk on secondary assessment or survey, it looks at different parameters and it's actually time consuming. So if you've got a patient in casualty and you also have to assess the full SOFA score, you know that the management of that patient is going to be delayed. So we have a simplified version of SOFA score, which is known as quick SOFA. And it has only 3 parameters that are readily available at bedside. And these parameters include your systolic blood pressure of less or equals to 100, respiratory rate of more than 22, and altered mentation, as I said, as assessed by your output. And the presence of at least 2 parameters is associated with worse outcome. So if you see this patient in your emergency resus unit and they've got at least 2 parameters, you need to think this patient is not a patient that you're going to admit to the ward, general ward, and put her in one corner. This patient needs to be admitted in your critical unit, either high dependency unit or ICU, because they've got mortality rate of at least 10%. So then don't turn your back on the patient. So when you look at your principle of management of sepsis, as we always say in our ESMO, all our ESMO modules, initial assessment, shake and shout, call a CAP. Your CAP is your circulation, airway, and breathing. And you do your secondary survey where you look at your big 5, forgotten 4, and your core 1. And it's always important to suspect or recognize sepsis early. And then after you recognize or your sepsis, you must think of your sepsis bundles. And time is life. And your sepsis bundles were actually derived from management of general population, and they are actually from our surviving sepsis campaign. So I will also elaborate more on this. And you must know that time is life, and 3 to 6 hours matters most. So when you look at your bundles, we've got a bundle, first bundle, which is your 3-hour bundle. And this 3 hours start from the time of your triage, irrespective of where your patient is. If your patient is in a CHC and is assessed as a maternal sepsis and she have to be moved from CHC to level 2 hospital, you calculate your time from that time when the CHC sister or a doctor have assessed the patient, which is your 0 hour. And management of the patient should start at that time. So if your patient is hypotensive, you resuscitate with 20 to 30 mils per kg of IV crystalloids. You need to take cultures immediately and cultures of any possible source. Besides your blood cultures, if you see any products or any pus, send a specimen for cultures. And you give broad spectrum antimicrobials within the first hour. You need to measure your baseline lactate and your urine output. I'll also elaborate more on those later. So your second bundle or your 6 hour bundle, this means, as I said, your first is your 3 hour. It means by the three hours, all those things need to be completed. And your 6 hour bundle is mainly where you reassess your patient and you sort out your source control. And this includes your reassessment of your lactate clearance, your perfusion status, and as I said, your source control. So when you look at your first bundle in more depth, if your patient is hypotensive, actually I've seen around whereby a person assess the patient or patient is in shock and they connect a Ringer's lactate or normal saline and they say give fluids at 125 mils per kg per hour. That's not how you resuscitate your patient. So you're gonna have to get that patient's weight. If your patient is weighing 50 kg, you're gonna calculate, take 30 multiplied by 50, which is gonna give you 1.5 liters, and you're gonna run through that 1.5 liter within the first 3 hours. Obviously, you need to take note of those patients who are at risk of capillary leak and pulmonary edema, like your pre-atlantics and your cardiac patients and all that. However, the basic is that you need to run this fluid through. You don't have to titrate them and say, I'm gonna run this at 125 mils per kg per hour and reassess after 8 hours. That's not how we're going to manage the patient in the first 3 hours according to the Surviving Sepsis Campaign guidelines. And then during that, it's also important that you need to reassess perfusion status frequently using your dynamic clinical parameters. And we all have blood pressure monitors. We can calculate pulse every around our bedside. So this we can do them as frequently as 15 minutes until we are happy that the patient is responding. And your target goals includes, as I said, your improving shock index, urine output of at least 0.5 mil per kg per hour, and the mean arterial pressure of at least 65. And this is in the patient that you assume that they were normotensive before they got sick. And if the patient is not improving after at least 3 hours, despite adequate fluid resuscitation, you need to start your vasopressors. And as I spoke about your lactate clearance, any patient who's got a lactate of more than 2, we all know that lactate is a product of tissue ischemia, whereby your cells will undergo anaerobic metabolism and produce pyruvate that will be converted to lactate. So your patient is ischemic, they won't perfuse, and you need to make sure that you monitor that lactate. And a lactate of more than 4 is actually critical. And you'll see from your baseline lactate, if you have to repeat this base lactate after your 3 hours of resuscitation, this lactate nicely clears as your patient improves clinically. Thirdly, you will need to initiate broad spectrum antimicrobials within the first hour and obtain routine blood cultures, as I said, before starting your antimicrobial therapy. However, it's important that you do not delay initiation of your antibiotics because you are still running around the hospital looking for blood cultures and all that, because any hour delay in initiation of your patient's antimicrobials is associated with at least 8% mortality. Then you identify your site of infection and you perform source control as soon as feasible, at least by the 6th hour. And this will include laparotomy if it's necessary, plus minus hysterectomy. So when you go to your secondary survey, obviously, as I said, you look at your big 5, forgotten 4, and your core 1. It's imperative that you obtain that patient history, either from the patient if it's possible, or any collateral history, and you do your organ system evaluation. So looking at your systems, your big 5, which is your CNS, your CVS, your respiration, your respiratory system, liver and GIT, and your renal system. Your CNS, crude AFBU, your CVS, look at your shock index, is the patient tachycardic, respiration, is the patient tachypneic, and you remember that your respiratory system is the one that usually actually first compensates in your acid-base status abnormalities. Your sets, if your patient actually have a set of less than 90, you should be thinking of ICU at that time. Abnormal liver enzymes, glucose, you'll have a patient who have either hyperglycemia or hypoglycemia, and you want to aim for normoglycemia in your sepsis patient. Check your abdomen, exclude any signs of acute abdomen and your bowel sounds. And obviously, if there's any signs of acute abdomen, you're gonna take that patient to theater and sort it out. Your renal system, perfusion, you assess your urine output. If you've got a patient who's got oliguria or anuria for at least 6 hours, or the patient has got deranged kidney functions, especially your creatinine, you know that patient is in acute kidney injury. And if you don't resuscitate this patient, they can actually even end up with chronic renal failure. Your forgotten 4, you look at your hematological system, immunological, endocrine, and your musculoskeletal. Patients with sepsis are prone to thrombocytopenia, elevated white cell count. HIV status is important. You know, in immunocompromised patients, they are more at risk and they actually die more. When you look at the new, the maternal sepsis definition, actually, it doesn't only look at the pregnancy-related sepsis. It also look at non-pregnancy-related infections and sepsis from patients who have ectopics and septic miscarriages. And the patients who are HIV contribute, actually, they are amongst also the top leading causes of maternal deaths. So HIV status is very important. How immunocompetent is your patient? And identify all the possible opportunistic infections that are associated with HIV. Your temperature and your glucose and your DVT all need to be assessed. Obviously, your core 1 is the business of the day, where you look at your genital system, your abdomen, your uterine size, any signs of peritonitis, is the cervix open, are there any foul smelling, products of conception, and or any discharge. And when you look at the possible common sources of your sepsis, as I said, pregnant women, they are also prone to other infections out of pregnancy or as other general population. So you assess your patient from head to toe. Does this patient have sinusitis, mastoiditis, any signs of meningitis, pneumonia, breast abscesses, pyelonephritis, appendicitis, septic episiotomies, etc. So until you assess this patient from head to toe and know what is the cause or what is the source of your infection, you won't be able to manage this patient and they will actually deteriorate under your care. So when you look at your parenteral antibiotics, start antibiotic therapy as part of initial resuscitation. And as I said, within the first hour from triage. Patients should not go to theater until 2 hours after starting antibiotics. This is just basically to ensure that adequate tissue levels are there. And what antibiotics do we usually use? We always use, say, go empirical. You get a combination of your cephalosporins. If not available, you can use your ampicillin or clindamycin plus your gentamicin, provided your renal functions are normal, plus metronidazole. This empirical therapy will cover your both gram-negative, gram-positive, and your anaerobes. And obviously later, as you get your culture result, you escalate your therapy according to your culture and sensitivity. And as soon as you stabilize your patient, as I said, source control, you take your patient to theater, they require laparotomy or evacuation. If you evacuate this patient and your uterus is still large at around 16 weeks, or they have organ dysfunction, 1 or 2 organ dysfunction, you need to consider hysterectomy in this patient. And just to recap, on your maternal sepsis, it's imperative that you recognize it early and you manage the patient accordingly. You need to think sepsis bundles and implement them immediately, irrespective of where you are. You need to monitor this patient, continue resuscitation, monitor, continue resuscitation, monitor until you get it right. And lastly, you need to identify your site of infection and obtain your source control. I will just show you a video on how you do your MVA, and then after that, I will just go through a few slides.
When preparing for the procedure, have several sizes of cannula available. Select the appropriate cannula according to the size of the uterus and amount of dilatation present so that there is a snug fit through the os, thereby maintaining a vacuum. To create a vacuum in the aspirator, begin with the valve buttons up, the plunger positioned all the way inside the cylinder, and the collar stop in place. Push the valve buttons down and forward until you feel them lock. Create a vacuum by pulling the plunger back until both plunger arms are fully extended, snap outward, and catch securely on the wide sides of the cylinder base. Begin the procedure when the woman has given her permission. Confirm that the uterine size is 12 weeks LMP or less. Inspect her reproductive tract for signs of infection or trauma and manage accordingly. Implement the pain management plan. Perform cervical antiseptic prep. If necessary, perform a paracervical block. Place the tenaculum and apply gentle traction. If dilatation is necessary, mechanical dilators can be used. A cervical ripening agent, such as misoprostol, can also be used. Ensure that the parts of the instruments inserted into the uterus do not come into contact with non-sterile surfaces, including vaginal walls. While gently applying traction to the cervix, insert a cannula just past the cervical os and into the uterine cavity. Alternatively, move the cannula slowly into the uterine cavity until it touches the fundus, then withdraw it slightly. Rotate the cannula while gently applying pressure to help ease insertion. Attach the charged MVA aspirator to the cannula, holding the tenaculum and the end of the cannula in one hand and the aspirator in the other. Do not push the cannula further into the uterus. Press the valve buttons in. Suction will start immediately. Evacuate the contents of the uterus by gently and slowly rotating the cannula 180 degrees in each direction while using a gentle in and out motion. Do not withdraw the apertures of the cannula beyond the cervical os, as this will cause vacuum to be lost. Blood and tissue will be visible through the cannula and in the aspirator cylinder. Remain alert to signs of complications, and if they appear, stop the evacuation by pressing the valve buttons. If the aspirator becomes full, depress the buttons and disconnect it from the cannula. Either replace the aspirator or empty it and reattach it. Signs that indicate the uterus is empty include red or pink foam without tissue passing through the cannula, a gritty sensation as the cannula passes over the surface of the evacuated uterus, the uterus contracting around the cannula. The patient may also feel increased uterine cramping. When finished, depress the buttons and disconnect the cannula from the aspirator. Alternatively, withdraw the aspirator and cannula together without depressing the buttons. Keep the instruments available in case re-aspiration is required. Empty the aspirator into an appropriate container. Inspect the aspirated tissue for quantity and presence of products of conception. This will indicate whether the evacuation is complete. If retained tissue is suspected, repeat the evacuation. Once the procedure is complete, assess any blood coming from the uterus. If significant bleeding continues, manage accordingly. Perform any concurrent procedures. Immediately process instruments. All instruments that are to be reused should be kept wet until they can be cleaned. Reassure the patient that the procedure is finished and monitor her condition. Provide clear post-procedure instructions to her and provide contraceptive counseling before she is discharged.
So following the procedure, you need to counsel your patient on expected symptoms and signs of danger. Like if there's any increase in pain or the patient start to bleed or they start getting abdominal pains. And remember, usually after this procedure, we cancel them and discharge them home. So they'll need to observe these signs at home. And you also need to talk to them about when they can resume their sexual intercourse, talk to them about contraception and how they should grieve. And we need to check for RH status in those patients who are RH negative. We need to give them anti-D and discuss with them when is it safe to conceive again. And usually there's no like robust evidence to tell you when the woman can fall pregnant, but we usually say 6 months or more. That will allow time to heal and even the grieving process, because sometimes women feel like they are responsible for the pregnancy loss and they want to actually try to replace the loss as soon as possible, thinking that's part of healing. And it's also important to have a follow-up appointment also with the partner for them to understand that whatever that happened is no one's fault and it can happen to anyone. And at least 15% of women will have these spontaneous miscarriages. And if you can identify the cause, it's always important to counsel them also on the cause and treat it so that same doesn't repeat itself. So just a word on ectopic pregnancy. It's important that you do a pregnancy test on all patients of reproductive age. If positive, you need to locate the site of the pregnancy. Most of the pregnancies will be intrauterine, and you need to continue the patient's management as the bank plus guidelines. They must attend the antenatal care and they should get all the care that pregnant women get. If not confirmed, you need to do your quantitative beta HCG. And your beta HCG, if it's less than 1,500, you won't be able to see an intrauterine pregnancy on sonar. So you may have to actually closely monitor this patient and repeat it after some few days. Just make sure that the patient is not acutely ill. And if your beta HCG is more than 1.5, you should be able to see intrauterine pregnancy on your transvaginal ultrasound. And if it's more than 5,000, you should be able to see your intrauterine pregnancy on an abdominal sound. If the uterus is empty, you need to have high suspicion of ectopic and you need to look for dead pregnancy. If in doubt, you refer the patient to the next level of care where investigations like laparoscopy can be done and the pregnancy can be identified and be treated as such. So just in closing, usually I give few scenarios and I think you can take these scenarios and you can go and work them, do them at your own time and try to practice around them. You've got a 22-year-old para 1 gravida 1 who's day 3 post-cesarean section for fetal distress following induction of labor for prolonged pre-labor rupture of membranes at term. Your patient's blood pressure is 110/55 with a pulse of 135 with a temperature of 28.4, 28.5, and the patient is tachypnic at 24. You can already see that this patient is in septic shock, and then you'll have to manage her, as I said, according to your bundles of care. And these are the common scenarios actually that are very familiar that you'll see in your patients when you are doing your rounds and all that. The second patient It's a 34-year-old para 2, gravida 2. She's day 5 post NVD. She presents to emergency department with shortness of breath, abdominal pains, and copious yellowish per vaginal discharge. You need to see how you're going to work out how you're going to assess and manage this patient. With that, I'll say thank you, and together let's grow South Africa in the journey to save lives. Ngiyabonga. Thank you very much.
Siyabonga nathi, Dr. Sylvia. Thank you so much. And I must tell you, the people who have been listening, we have also medical students, we have interns, and this was a very good presentation, which was well understood by all level of doctors. Doc, let's just go straight to it, to the questions. Anonymous is saying, afternoon, thank you for, sorry, the Anonymous is saying, let's start with Mudisa. Anonymous question, we'll get to it. Mudisa is saying, can NVA be done on previous cesarean section, Dr. Sylvia?
Yes, we can. As long as the patient is stable and she fulfills the criteria for manual vacuum aspiration, you can do MVA.
All right. And then the other question from Matume Mushopia is saying, do we give ROGAM to all RH negative patients, even after just an event?
Remember, if you see your patient who are RH negative, majority of these patients, your miscarriages are emergencies. So they will present to you as incomplete or threatened, which subsequently with incomplete, and you're gonna manage them there and there. And in the patient who actually is term and all that, you'll go and do who delivers vaginally at term, you'll go and assess the baby's RH and work them up. And in miscarriages, you don't have that luxury. So if your patient is RH negative, it's safer to give them a anti-DIM.
Okay, thank you, Dr. Sylvia. And the other question is saying, it's from Anonymous as well, is there evidence that falling pregnant within 6 months of miscarriage will result in loss of the following, loss of the baby? I think that's what he wanted to say. Loss of the subsequent pregnancy, that's what he says. And when is it ideal to resume sexual intercourse post miscarriage? You know, Dr. Cebekulu, that in African culture, if you had miscarriage or you have children, you had a baby, there's a time where you would not have sexual intercourse. When is ideal scientifically? And maybe even in African culture, you can even advise us if you remember.
Dr. Dakalo, I'm an African, but I don't know all the African practices. But as I said, there's no robust evidence as to when the woman should fall pregnant. But I said, ideally, it's better to allow the woman at least minimum of 6 months for them to heal and to grieve, so that when they fall pregnant, they know that they really want to do it again. And I think Anonymous also asked, are we sure, or is there evidence that the woman won't have another pregnancy loss? That one basically depends on what was the primary cause. If your cause, you manage to identify and treat it, and you can only hope that it's not going to repeat itself. And when it comes to when to resume your sexual intercourse, women behave differently, believe differently. I know in Zulu cultures, you are not supposed to sleep with your husband for at least 3 months. So I don't know about other cultures, but the minute, I think it's only ideal that when the woman feels that she's comfortable and she's healed, because remember, your sexual intercourse also involves your psychological interaction. So when the woman thinks that they are ready, I think they can resume intercourse at any time they are comfortable.
we've got Handsome Dube. Handsome Dube is saying, Handsome Dube is one of our doctors who is really following us every day, every bi-weekly, all the sessions. Handsome Dube is saying, Dr. Sylvia, thank you so much. This was very informative. He enjoyed the session and he's saying it was very excellent talk. This is Handsome Dube from Zimbabwe. And then
Thank
there's
you,
another,
Handsome.
yeah, say that again.
Thank you, Handsome. You're welcome.
Lovely. So, and the other comment from Katleho Mukwena. Katleho is saying, afternoon. Is it possible to access these slides? Sorry, cannot stay for the rest of the question and answers. And I'm on duty. This is Mukwena from is Batatoa Hospital. Do you know this place? It sounds like Eastern Cape. Batatoa Hospital.
No, I don't know it. I don't know it.
Okay, brilliant. But this is just an evidence to show that you've been listened by the whole of South Africa, not only Limpopo, not only Zimbabwe. It's everyone listening to you, Doc, and they are so excited. Yes, the slides will be available. I know I've been behind in putting YouTube recordings, but I'm on track now. We will be able to get those. So the other one is from Katarisa, our also favorite doctor, is always with us twice a week. Katarisa is saying, thank you so much for the presentation. Katarisa said, doctor from Cape Town. And then we also have Nazim Latif. Nazim is saying, thank you so much. This was an excellent presentation. And we have also Katleho. Katleho is saying that that hospital is in Germiston, Ekurhuleni, Gauteng. So it is Gauteng, though.
Yeah, I know Jamestown.
Yes, and then we have another, I think this is anonymous from EDH, Ops and Gynae Nursing Team. Thank you so much, doctor. They're saying thank you for the presentation. Yes, and I know people are saying, because it's 3 o'clock, we're still busy with our day-to-day activities at work. We are struggling to be able to stay throughout the whole process, but we are waiting for the YouTube video. It's also coming, and also doctor is gonna send us the slides and we'll share with everyone. Thank you so much. Doc, let me ask, for a patient who is having some form of sepsis and DIC, and then you realize that the sepsis is coming from the uterus, which needs to be taken out, what is your approach? Because DIC is caused by sepsis, and the anesthetist is saying that wait for the DIC to resolve, or sometimes when there's also renal impairment or acute renal failure, they're saying that wait for the patient to get better and then you send that to theater. And the question from the Ops and Gynae is always, this is all caused by the fact that the patient has sepsis. So what is your approach, Dr. Cebekulu, in such a patient?
Okay, so thank you, Dr. Dakalo. As I said, any patient with 2 or more organ failures, they need to have a hysterectomy. And your source control should be done at least by the 6th hour. I know sometimes anesthetists can ask for things, sometimes we don't agree with them. Get an ICU patient for that bed. Assure the anesthetist, if your patient is in DIC and you have assessed the severity of your DIC, because the thing that you can have is either the patient's got thrombocytopenia or the patient's got elevated INR. During that stage whereby you are resuscitating your patient, you try to correct all those abnormalities as soon as possible. And you take the patient to theater, operate the patient, take out the uterus. If you are worried about a possibility of bleeding or oozing, pack that abdomen, take that patient to ICU, bring them back. Obviously, you're gonna continue your optimizing your management, then you bring them back after 48 hours to remove your pegs. I know putting pegs in a patient who's septic, it might be of compromise to the patient. However, if you have to balance between the possibility of patient bleeding or patient dying from sepsis, you have to try to balance both. So if you need to operate here with platelets running, you remember your platelets half-life is 4 hours. So you can't transfuse the patient platelets and say, I'm going to operate after 12 hours. If you need to give a platelets on the table, run the platelets as you are operating on her. But I wouldn't say wait for more days, because until you get your source control, that patient won't get better. And if you look at the review that we wrote on ONG Forum 2018, Too Little, Too Late, majority of women died from sepsis and they still had their uteruses in. And that's very sad. That's painful. So the anesthetist should actually help us towards sorting out the problem of source control rather than delaying the process.
Marvelous. So, because it's talking about theater, because I mean ICU, because some areas they will tell you that there's no patient who comes with septic miscarriage with the uterus in ICU. So you have to go and take that uterus out.
Yes, yes.
You know, and the anesthetists say that no, you can't take the uterus out because the patient is still in DIC, the patient is still in acute renal failure, you need dialysis before, you know, so those are the issues which I think we as the team have to work together around it.
Yeah, I think at the end of the day, your teamwork counts most, because you can still also, even if take your patient to ICU during that 3 hours of resuscitation, or 3 to 6 hours of resuscitation, you can still take your patient to ICU, resuscitate your patient, optimize your patient, take them to theater, operate on them, and bring them to back to ICU. I don't think we should put barriers in areas of care, because we just want to be comfortable in our own corners.
Absolutely. So I had a mentor of mine, he passed on, but he used to say, if a patient has a septic miscarriage, the patient needs to be operated or needs to be evacuated or operated yesterday. Okay, if the patient comes to the hospital now and with septic miscarriage, the surgical intervention, whether it's an evac or taking out that uterus, needs to be done yesterday. Yeah, the name comes back. It's his soul rest in peace, Dr. Matindi. He was a consultant in Somerset Hospital. He taught us a lot, originally also from Zimbabwe. So he was a great mentor. So that was his idea. What do you think about that?
Obviously, yesterday the patient was not there, but at least within 6 hours of your triage, the patient,
So he was emphasizing the agency of, you can't just.
Yes. So it's important, because what happened is that, as I said, don't put the patient at one corner and say, I'll come and reassess after 8 hours or tomorrow, because the minute you do that, that patient is going to die. So you need to get to the bottom of the problem as soon as possible.
Absolutely. So, and the other part is, tell me about the transferring of a patient with an ectopic pregnancy. Ruptured ectopic pregnancy, patient is 300 kilometers away from the or another hospital, and we are told that the patient, they cannot operate her because it's increased BMI, but it's ruptured ectopic. What is your advice? Because in peripheral hospital, more especially in the hospital we work in Limpopo, we don't have anesthetists in every hospital. So we have medical officers who are doing anesthetists. So sometimes they say they're not comfortable because the patient is increased BMI, short neck, but now she's in front of you with a ruptured ectopic, and you need to send her to a tertiary hospital, which will take another 5 to 6 hours. What is your opinion about that?
It's a serious system problem, because ideally an ectopic should be operated at any level of care, being it level 1, level 2, or level 3. And the minute you start having patients moved from one point to another, that compromises the and the impacts on the patient's survival. So I would say if that's a situation, that institution need to make sure that the patient resuscitation begins where they are and they get that patient out of there as soon as possible, and the receiving hospital should be ready waiting for the patient for that. I think that's all that I can say for now, because I mean, if I have to go through the system challenges and all that, I'll finish the whole day talking about
I
it.
know, I know. So Lloyd, there's a question from Lloyd. Lloyd is saying RH can be deferred at least 12 weeks when it's complete spontaneous abortion, but not when there is manipulation. How true is that, Dr. Sylvia?
RH can be deferred.
He's saying that as far as he knows is that if the pregnancy is less than 12 weeks, and it was complete spontaneous abortion where there's no manipulation, you don't necessarily have to give RH for, ROGAM for RH negative.
And what about the 12 weeks?
Less than 12 weeks. The gestational age, does it matter when you can give ROGAM for RH negative? I think
Okay,
that's
remember this patient that we are talking about, the one who's gonna have do MVA, is a patient that you're gonna obviously evacuate the patient, and you don't know. I mean, the whatever happened before the patient gets to you, you are stuck with her. You have to evacuate and you have to give her ROGAM. Unless I don't understand, unless if he's telling us that you don't have to give a anti-D if the patient's got other forms of miscarriage, like your complete miscarriage and your what other miscarriage? I think I can only think of complete miscarriage. If the patient comes to you and miscarry, abort, the other thing is that you don't know what stimulated, what caused the miscarriage.
Yeah, I think that's basically what he was asking. That if it's a complete miscarriage where you don't have to do an evac and it's less than 12 weeks.
My concern is that you don't know what initiated that. As much as we say 15% of miscarriages can be spontaneous, we don't know what initiated the process. So I think it will be safer to give the patient ROGAM than not to give it.
Okay. So there's another question from Dr. Mushupia. Dr. Mushupia, thank you so much. Tell us which hospital you're working in. Dr. Mushupia as well is always with us, and thank you for joining us, and thank you. Dr. Mushupia is saying at district hospital, the unsafe miscarriage with false mailing discharge, even before doing gynae exam, how safe is it to do a DNC? Because he's worried about possible perforation of the uterus because of septic uterus, more especially when you are more than 150 kilometers away from the tertiary institution. So in a case where you're suspecting septic miscarriage and you're too far from the hospital, how safe is it to go ahead and do a DNC?
If the patient is complicated, Dakalo, if there's any signs of infection, you are concerned, don't do it. Send the patient away. Start all the resuscitative measures, start your antibiotics, give your fluids, send that patient to the next safe level of care. Because I don't want you to go and take that patient to the ward. Remember, you do your MVA in the ward without an anesthetist. You usually you give this patient sedation. If your patient is unstable, that patient, by the time you finish that MVA, you may not have a patient. So if your patient is unstable, within that 3 to 6 hours of your resuscitation, it should be enough time to get that patient to the next safe level of care.
Absolutely. Yeah, no, because you will be acting like a hero, and at the end of the day, you might be facilitating her death. Because a patient with septic miscarriage, as Dr. Sylvia is saying, We would ideally do it in theater, and it will be under ultrasound guidance to avoid this perforation of the uterus. And if you're doing it outside under nyamezela, under I'm sorry, when you're doing it, you may actually end up perforating and causing more problems. And perforations has actually occurs to the best of us, and you may actually end up sucking all those bowel coming from the vagina. And at the end of the day, you wouldn't have saved the patient. Okay, and then Dr. Mutumi is saying he's listening to us from Nobel Hospital. Doc, thank you so much. If we have to go through all these questions, I promise you will never finish. But I'm so grateful for you to give us your time, and thank you for joining us. We really appreciate it. Your last word, Doc.
Thank you, Dakalo. I just want to say thank you to Limpopo team for organizing such a wonderful initiative. And I hope with this, many women's lives will be saved. And it was very humbling to be invited as a speaker. Thank you.
We are so happy. Thank you. Marvelous. Thank you so much. I'm very sure that we're going to have more of this, and we will require your expertise at a later stage as well. Thank you so much, team. For those of you who have been listening to us, it was around more than 100 people listening. We really thank you, and we will meet you on Friday. Friday, Dr. Verenga is also back. Guys, keep well, and bye-bye.